Every single drug company turned us down. They said, well, that would mean we wouldn't get to sell our drugs to the people who don't need them.
We're about to hear a fascinating interview with the inventor of the calcium scan of the heart, Professor Douglas P. Boyd. And this scan has amazing potential, if used more widely, to let people know that they have extensive atherosclerotic disease present and that they have very high risk for a future heart attack. On the left we see a scan result, and there is no calcium present, no white in the scan. And this means that the person has very low levels of atherosclerotic disease because the calcium is brought in by the body to deal with the atherosclerotic inflammatory disease and to strengthen the arteries. This person on the left has a very low risk of a heart attack in the coming decade. On the right we see a stark contrast. There is a lot of calcium present, and this person will have a lot of vulnerable soft plaque, potentially actually blocking an artery and causing a heart attack. So this person is at high risk. And this is the beauty of the scan. It shows who is at high risk or who is at very low risk. Here we'll see on the screen the progressive process of atherosclerosis. And we'll highlight now that early in the process you begin to recruit calcium and get a calcified shell in the area of weakness. A little later you get a calcified plaque, and the calcium will be visible on this amazing scan. But now we see that it is quite a bit later that you actually have a rupture and you get a myocardial infarction or a heart attack. So the calcium will show up for a vast majority of people much sooner than the actual heart attack occurs. And this is why it is so pivotal as a screening technology. It shows you where you are heading quite a while before a heart attack occurs and allows you to intervene and resolve the root causes of this inflammatory progressive disease and essentially to save your life. We can see a recent study, and it agrees with all of the other studies on calcification technology. A person with a 0 has very low risk in the coming 10 years of a heart event. We now see that a person with a high score has a very high risk, perhaps 20 to 25 times more risk of a heart attack than a person with a low score. And this is the enormous power of this scan. It is far more powerful than all of the blood risk factors put together. Briefly, another study with 25,000 patients followed for 12 years. We can see that the people who originally had a 0 score, 99.4% were still alive after 12 years. But people with a high score, only 76.9% were alive after 12 years. So you can see the huge difference in outlook between a 0 and a high score. But note that people who have a high score can take action, intervene, and stop the progression of the disease. And in doing so, they can hugely reduce their risk. And again, this is the importance of using this screening technology more widely, because it gives people the choice and the option to intervene and essentially save their own lives. And with that, we'll move on and enjoy the interview with Professor Boyd, and I hope you enjoy it as much as I did. Thank you. We're here in the boardroom of Imitrex, a company run by Douglas Boyd, who was professor of physics at the University of California, San Francisco, and he has a very special story to tell us today around calcification and the CAC score. So delighted to meet you, Doug. Pleasure.
Nice to meet you. Wonderful to be here.
So you, perhaps if you start with your journey, physics is a hardcore science, one I have a huge respect for. There are a lot of softer sciences out there. And maybe a brief history of your journey into physics and how it culminated in being professor of physics.
So this is an interesting story because Russia is a topic of conversation nowadays. So in 1958, the Russians launched the first satellite to orbit the Earth. It's called Sputnik. And President Dwight David Eisenhower came on the television. I was a senior in high school. And he said that the Russians are ahead of us and we have to push very hard to catch up. And he wanted all the students to study physics. So I took that to heart and I went to college and I enrolled in the physics department and went on to get my PhD in physics. And then I came out to California at Stanford University in the physics department, and my first project was to work on a what we called a pion channel. It was a superconducting magnet system for treating cancer with pi mesons. So since we had the capability with pions to treat at 3 dimensions, we needed to know what the 3-dimensional shape of the tumor was, and there was no real way to do that at the time. We had a system called axiotomography from that was invented in Japan by Takahashi, but we didn't have a good way to image, cross-sectional imaging. So as part of the Pion project, we developed one of the first CT scanners, computed tomography, and the purpose of that scanner was for radiation therapy treatment planning. And that's how, then there's a long story after that, but that's how I got into this area of CT and so on. So CT took off. Godfrey Hounsfield developed his head scanner that was a brilliant development in medicine. And the next goal was to figure out how to make these scanners go faster. At the time, they were typically 60-second scans. At least, and the fastest that were on the drawing boards were like 5 to 10 seconds. So the goal, so when I went to UCSF, I told my professor, the chairman, Alex Margulis, I said, you know, I want to see if we can develop a scanner that would be fast enough to image the heart. And for that, you need far less than 1/10 of a second. So I started in January of 1976, and we had no idea how to do this. Talked to a lot of very smart people. We looked at a lot of things and finally hit on the idea of a scanning electron beam, and showed that idea to the National Institutes of Health, and they thought it was a good idea, so they funded us to build an electron beam CT scanner that's called EBCT today. And so in the early 1980s, I met Bruce Brundage, and he was the cardiologist at UCSF. He encouraged this work as being very important. We didn't know about coronary calcium yet. You know, we were just trying to image the heart, period. We didn't know what it could be used for, but we wanted to build a scanner that was fast enough. So the electron beam, by scanning electron beam, there's no motion in the scan, and we could get down to a 50 millisecond scan speed. That's 1/20th of a second.
Wow, and that, I suppose people might view that like, you know, a television set with XY kind of plates and a beam, and you're moving the beam rapidly.
Oh yes, it's like a television tube that has a scanning electron beam in it, but in this case we scanned the electron beam in a circle, and of course the power in the electron beam was about 4 orders of magnitude higher power than in a television tube. So it was very high powered to produce enough X-ray, because if you scan very fast like that, you need to have a lot of X-rays because you only have 50 milliseconds to collect 10 to the 7th X-rays. So that's what we did, and started making images and started imaging the heart. And we started noticing that there were these white specks in the heart. And what the heck is that? Those white specks are calcifications. They were known, they had been seen years ago before that in fluoroscopy. They're hard to see in fluoroscopy, you can just barely see them. But in CT, they stand out as like big snowballs in the coronary arteries.
Right, because calcium as a mineral, it really bounces those electrons back. And I guess autopsies, from historical autopsies, they knew calcification was part of the process, but no one could see it in a live person.
Yeah. So we were seeing these things and trying to think what the significance. And when we talked to the old school cardiologists, they said, "Oh, well, that's just normal part of aging." But we noticed that about half of the patients didn't have these calcifications.
Exactly.
And then with the researchers jumped in, people. Dr. Brundage began to do a lot of research and publish papers, and they began to notice that the people who had calcifications were the ones having heart attacks.
Right.
And the more, if they had especially a lot of calcification, they would tend to have fatal heart attacks. And the people who had no calcium were not getting heart attacks. So we said, oh, that's interesting. 50% of the population dies of heart disease, and we're noticing that 50% of the population doesn't have calcium, and the other 50% does. So maybe this is an early indicator that coronary artery disease is developing.
Right. So you, at that point, Doug, you're kind of working this out and saying, wow, it could correlate strongly, but perhaps you didn't yet fully realize how strongly it was going to correlate with more data.
Oh yeah, and the people like John Romberger and Professor Budoff at UCLA began doing multi-center studies and looking very carefully at different categories of patients, and it was very interesting. I'm a physicist, but the medical people took over, and they began learning all kinds of aspects, how this was affected by diet, how it was affected even by stress, all kinds of different aspects of this coronary calcification, which we finally realized was a marker for progressive coronary disease, and you could watch it progress. Yeah.
Right. And I think it was Rumberger who said that the calcification, just as you described, the higher the score, the more events, and it was independent of cholesterol, blood pressure, kind of everything.
All the so-called risk factors.
Yes.
Those were out the window. Yeah.
Yeah, and subsequently it was shown that calcification beats all of the risk factors put together in the algorithms, and then some, on its own, on its lonesome. So I think it's around up to 20 times more likely to have a heart attack with a very high score versus a low score or a zero.
Yeah, although it's very interesting, there is a subgroup. So what the rule of thumb is, from having zero calcium is good. You're good to go. Up to zero to, when you get up to about 100, you should start thinking about statins. 500, people with scores of 500 calcium, those are the people that generally have cardiac symptoms. They may have some chest pain or some exertional angina. When you go up and downstairs, you might start feeling it a little bit. And 1,000 is very bad. Okay. But there's a subgroup that go all the way through all those stages, 100 to 500,000 to 2,000 or 3,000, and have no problems. And those are the people who explain what the calcium is all about. The calcium is a repair process. When you start getting, because this calcium is not just calcium, it's a bone matrix. And it grows as a way of strengthening damaged coronary artery wall. The coronary artery disease eats away at the wall, so the bone matrix is laid down to save it. And for some patients, it works, and sometimes we call it laughingly ceramic coronary arteries. People have like scores of 3,000, but their whole arteries are coated with calcium, and they're good. They're okay.
And those people, I guess, it's often brought up about soft plaque. So if soft plaque calcifies and stabilizes faster than a soft plaque bursts, on average, you may have many of them, that person may be okay.
Well, I think once you have ceramic coronary arteries, there's no soft plaque anymore. So you're good to go.
They're possibly super rapid calcifiers of inflamed soft plaque.
Yeah.
And therefore they buck the trend. But on average, of course,
it's a small subset. Yeah. Very.
Okay, just in case people think it could.
But they're up until the time they're completely calcified. They're at risk. Yeah.
And I think
Professor Brundage describes it as the iceberg.
Yeah.
So if you see the calcium, you know there's many soft plaques
Yes.
underneath.
Yes.
And if there's no calcium,
And those soft plaques are at risk. Yeah.
actually on that question, just branching out now to the lack of uptake of calcification relative to how it should have been taken up in the past 30 years. One argument was that it doesn't see the soft plaque, which is a specious argument, but what would you say to people who suggest that? I still hear it sometimes.
Yeah. So yes, you could have some patients, and that's sort of like 1 out of 100 that would have soft plaque but no calcium visible, because the soft plaque comes before the calcium. But I think the large multi-center studies showed that that's on the order of 1 in 100 that would have a score of 0 but would have some kind of cardiac event. So almost nothing is 1 in 100 in medicine. I mean,
Certainly.
So yeah.
And I think to expect a test to be 100% perfect is absurd when the risk estimators you use are far weaker.
Yes.
It's kind of people in glass houses throwing stones.
Like random, yeah.
Yeah. So the other thing though that does come up, just looking at some of the challenges with calcification or arguments used to limit its use, tragically, the radiation. Now, I think it's around 1 millisievert nowadays, similar to a bilateral mammogram, but that argument often gets brought up as a negative point.
Yeah, so in cardiac imaging, we have competing modalities. You have the echocardiogram, which is ultrasound, and nowadays you get sent for an echocardiogram at the drop of a hat. So you have the echocardiogram, you've got the MRI, cardiac MRI. So both of those two are cross-section imaging like CT, but do not involve ionizing radiation. So those are the people who put out the propaganda about the radiation, because they want you to use their test and not use the radiation test. So people have the risk of a low exposure of radiation, like 1 millisievert, is very low and not even known. Originally it was based on data from Hiroshima, where they followed the patient for 50 years from 1945 up to, and now it's 70 years. But the Hiroshima survivors are now healthier than the other people. So it's not clear. There was a period of time when the data is very small. I mean, the risk is so small it's like 1 in 10,000 or something that you'll develop. The theoretical risk, by the way, is only theoretical. Is very small compared. It's comparable to smoking 1 or 2 cigarettes.
Yeah. It's
in that range.
I actually looked into this a little myself because I became so frustrated with hearing it over the past few years. And there was, for instance, a large an accident, radioactivity accident. I think it was in Brazil many years ago. And those people got 30 to 50 times the 1 millisievert. And it was an acute, localized exposure. So it wasn't like it was spread out. And they tracked them for 20 years and found no difference with the controls in the population. And Chernobyl, similarly, much higher doses.
And Hiroshima, now they're living healthier. Maybe there's some other reason why they're living longer and healthier. But you could also theorize that low levels of radiation are an immune system enhancer, and that it's good. So the answer is nobody really knows, and if it is, it could be either good, could be bad, but whatever it is, it's pretty small.
Whatever it is tiny, exactly, and nothing compared to the other bad things we can do in our lives to increase our risk, yeah.
And I should mention, just to complete the sentence, that the ultrasound, echocardiogram, and the MRI cannot see calcium.
And their predictive power, I mean, for someone who has a major issue, they are diagnostic of certain things, but they cannot be used as a predictive screening for individuals to find out their real level of risk.
Yeah.
Yeah. And the same with the stress tests can be horrifically wrong also. The other argument was there is no RCT, and as a physicist and a man of data, the randomized control trial. It's still being said that there's no actual prospective randomized control trial with scanning, no scanning, and then showing that the scan result and subsequent change in treatment or intervention results in a significant or major difference. I guess we know it will, but I don't think there's a particularly powerful RCT.
If you have coronary disease and you're on your way for a coronary event, it's better to know it and have it taken care of. But the best evidence, I'm not sure about the study, but the best evidence is called secondary prevention. 50% of the people who have heart attacks die from the heart attack. It's usually the first symptom, heart attack. But 50% survive. So the 50% who survive their heart attack are at risk to have a second heart attack at some point down the road, 1 or 2 years later. So there's a program called secondary prevention that involves diet, lifestyle, exercise, and secondary prevention is successful in preventing a second heart attack. So if secondary prevention is proven to prevent secondary heart attacks, why not apply secondary prevention to people before they've had their first heart attack? And it should have the same result. So there's a thing that is understood by physicists and mathematicians. It's called inductive reasoning and deductive reasoning. It's not accepted in medicine, but if secondary prevention is so successful, why wouldn't it be successful for the primary heart attack also?
In advance of the heart attack, of course.
Yeah. So you take the people with these high calcium scores and put them on a secondary prevention program and prevent having that first heart attack.
And of course, I agree, there's no question, but the scan's power should be leveraged massively more than it is because of that very inductive reasoning. Now, there are the various drugs and there's lifestyle. Now, I'm involved in more the lifestyle and nutrition and how it affects the progression of coronary disease. And I think in the coming 10 years, there'll be a lot more understanding around the interventions that will be really helpful in nutrition. I think to date, we've had kind of low-fat interventions and they haven't been quite so successful. But when that occurs, I believe, then there will be even bigger artillery to bring in for people who have a high score, more actions they can take that could really enhance, the slowing down and the stopping of progression. So it can only become more valuable in the future. The attempts to kind of suppress the scan that were shown in the Widowmaker movie that David Bobbitt and IHDA got made, there was a pretty strong resistance for many decades, and I've touched on some of the arguments that were brought up. But you also had another very interesting story about the Mayo Clinic, which was quite striking as to how the medical business works.
Yes, well, we have in this country for-profit medicine, and the human mind is, tempted by money and so on. But the Mayo Clinic was, and John Rumberger was originally there, but the Mayo Clinic team did some of the early research on coronary calcium, and they were, in fact, they published a study of 100 patients, and they had 100 patients with scores of 0, and no one had a heart attack, and all the other patients did. And that study was written up in the New York Times. It was very significant at the time. This was early on. So the Mayo Clinic said, oh, this is fantastic. We can predict not only who's going to have a heart attack, but we can predict who needs an angiogram or not. And so the Mayo Clinic has cath lab. I guess they have 4 or 5, maybe more cath labs. And but what happened was the group that was doing the coronary calcium research studies and the multi-center studies wanted to set up a service for coronary calcium screening at the Mayo Clinic. And they applied to the administration of the hospital for a phone number so people could call up. They could put a phone number, and people could make appointments and come in and get a screening study. And it was squashed by the administration. And the argument was that at the Mayo Clinic, 50% of the angiograms turn out to be normal. And if we start doing this coronary calcium screening, we're going to lose 50% of our cath lab business. And that's 25% of the revenue of the whole institute.
Wow.
So we had the same thing when we talked to all the drug companies about the statin drugs. We talked to Merck, Bristol Myers, all those. We said, would you guys want to team up with us, because we could predict the people who need to be prescribed a statin drug. We could help you with that. And every single drug company turned us down. They said, well, that would mean we wouldn't get to sell our drugs to the people who don't need them.
Which is, to be honest, not unexpected attitude, but it's quite shocking in a sense also.
But it's not just in this area, it's every area of medicine. So this is not, cardiac isn't the only part of medicine that has this kind of problem.
True, and medicine is a high revenue, high margin business, and threatening high revenues or margins will always be highly resisted. But I didn't realize that the story also applied to the drug manufacturers as well as the Mayo Clinic, so that's fascinating, Tug, to be honest.
Yeah, and we didn't even bring up the stent people.
Oh, well, the whole stent question,
that's
is another whole story.
Yeah.
But I think there's another parallel with the insurance industries. In the Widowmaker movie, I can't recall the guy's name, but he explained that no one was interested from the insurance companies because people move every few years. So if they actually cover this test and people are identified and they do avoid a heart attack and get healthier, some other company will probably get the benefit. So they had no interest. So even the insurance companies, it was a problem. Yeah. On the other technologies then over the past 30 years that have developed, like the MRI, I guess, but there's IVUS, intravenous ultrasound, and all these other technologies, they still don't do what the calcium scan does, a quick one-shot scan, and it gives...
Well, they're invasive. So as soon as you start pushing a catheter into someone's vein, you're at risk to do more damage than benefit. That's the problem. So those are all invasive studies. They may be justified if there's already a diagnosis of coronary disease and they're trying to characterize it better, figure out where they can put the bypass and that kind of thing. That would be good, but it's not a screening test. A screening test cannot involve anything that's poked into the body, and it can't involve things like iodine, IV or any of those. The beauty of the calcium scan is you just come in, lie down on the table, and in 2 or 3 minutes you're out of there. And you haven't risked something for the benefit of having the knowledge. Now, do I have it or don't I?
Yeah, and it's huge knowledge, and as we said, the risk of radiation is a distraction, as we discussed. And even the CT angiogram is higher radiation, and there is a dye introduced. So
that's not a screening test, but but that's a test that can look for these soft plaques and these narrowings that traditionally were considered to be important.
Right, so subsequent to a CAC scan, if you have a high score, they can be further investigations, yes, but they don't provide the screening.
Yes, it's a diagnostic test, not a screening test. Yeah.
Well, I think, Doug, I think we've covered the history and the capability. I think that's an incredible journey you've been on and are still on. So huge respect, Doug, for that. Incredible.
Yes, and the NIH is still supporting this after all these years. So the original cardiac scanner was developed under an NIH grant, and we have an NIH grant for this stuff.
It's fantastic because I know the NIH, their funding has been under pressure. It's very hard to get grants, so it's a credit to the level of what you're achieving to continue to get that. And I'll also just mention, I'm here having this fantastic discussion with yourself thanks to Irish Heart Disease Awareness and David Bobbitt, who is enabling us to get the message out in calcification, and finally getting to talk to the inventor of the technology. So thank you very much, Doug. It was a pleasure.